everyone. I'm Dr. Vinay Satwah, and I'd like to take this opportunity to thank Dr. Craig Walker for this wonderful invitation to be a part of the NCVH Digital Education Series. Today, I'll be speaking a bit about the need for intravascular ultrasound in treating the deep venous system. Before I get started, these are my disclosures. I think it's very important as we're evaluating our patients in our respective clinics. Many of their patients are walking around with chronic venous insufficiency. And over the years, we've become very good at detecting that. Thankfully, our patients also are benefiting from this. Earlier detection leads to more preventive measures, which leads to less adverse outcomes. And so the question is, being that we are so advanced on the chronic venous insufficiency side in the superficial vein space, when do we think about actually imaging the deep venous system? Because for the most part, the deep venous system has only been looked at for blood clots. And we know that when blood clots are ruled out, typically the deep venous system is not thought of. And so I'd like to share with you in a superficial vein practice when it's important to think about imaging the deep venous system. The first subset of patients are patients that will come to your clinic with the run-of-the-mill symptoms. And the run-of-the-mill symptoms will be heaviness, achiness, tiredness, swelling, cramping, night cramps, restlessness. And they'll be saying all the right things to you. And when you go to get the patient an ultrasound, the vascular technologist comes to you and says that, "Doc, I have not found any venous insufficiency." That is a very, very important key factor when you have patients that are coming to you with these symptoms, but the duplex findings are inconclusive. Similarly, along those lines, when you have patients that are presented to you with advanced venous changes clinically, meaning C3 and above, patients that have already come with swelling to your clinics, and you're evaluating these patients, they may have swelling, they may have hyperpigmentation and chronic skin changes, or they may have even advanced to an ulceration that may have healed over time. And you go to get these patients a superficial vein study, and their venous duplex study comes back either no abnormalities or with minimal abnormalities. Again, that is very key in understanding that you have to look deeper. When a patient comes to you with the same clinical features and you go ahead and rightfully treat their symptoms by addressing the superficial venous insufficiency, and despite you doing a great job, the patient does come back and say, "I still have symptoms." And you do the ultrasound, and the ultrasound shows that the superficial vein is indeed closed. So technically, everything was done great and the vein closed. However, the patient's symptoms did not improve, and this continues to occur over long-term follow-up. We must think further in the deep system. Along the lines, if we do enough of these, we will note that some superficial veins may recanalize. Some may recanalize earlier, some may recanalize down the line. And while it's a clinical decision as to whether the vein needs to be ablated again or not, or should we watch it, when a patient comes back with recurrence of symptoms accompanied by recurrence of previously treated veins or recanalization, we must think outside of the superficial vein space. And then finally, patients that walk in our clinics that may have had a history of a blood clot, albeit years ago, we know that 48% of these patients may have postthrombotic syndrome. And it behooves us as clinicians to make sure that we think about postthrombotic changes that may have occurred years later with chronic scarring within the veins that is leading to their symptoms. So any patient that you suspect having postthrombotic symptoms must have further evaluation in the deep venous system. So now that we know how to apply the knowledge and how to further evaluate these patients and who to evaluate, the question now is, what are our options? And like many things in medicine, we do have options. Let's start with the least invasive option. That is transcutaneous pelvic ultrasound. It's a very helpful and very well utilized test across the board. Ultrasound is least invasive, but we must understand that getting a pelvic venous ultrasound is different than getting just a regular pelvic ultrasound. A pelvic venous ultrasound requires a higher level of skill set by our vascular technologists. There are various maneuvers and various images and windows that need to be obtained. We must also remember that due to the anatomy in the area, there's a lot of bowel gas that may be overlying the pelvic structures that we need to see. And so some of these patients, all of our patients in our practice, need a gas prep and need to be NPO after midnight. Even despite our best measures, it still may pose as a challenge in patients that are obese, because again, there's a lot of tissue that ultrasound probe needs to penetrate through. And despite all of that, even when a patient has a normal or negative pelvic venous ultrasound study, it is still a weak negative predictive value. So in other words, these patients, if they have classic symptoms and the ultrasound still comes back with the normal limits, there still may be a need for further invasive evaluation. I am not a radiologist by disclosure, but CT venograms and MR venograms can be quite helpful. And here you can see a very nice axial image and transverse image of a left common iliac vein being compressed by the right common iliac artery. And we must understand that this is very operator and user dependent. It depends on your radiology colleagues in your community to obtain these kind of tests, but they're not very simple and easy to obtain. Same thing along the lines of an MR venogram. And again, they're very helpful tests, don't get me wrong, but they may be misleading. Why? Because once again, they can be reader dependent and operator dependent. And ladies and gentlemen, this is a two-dimensional view of a three-dimensional object. And so we must be very careful when we're trying to apply principles in a patient that has potential venous outflow obstruction, and we're making decisions based on just a two-dimensional view. So getting to my point in our talk, why is IVUS guidance so important? Well, for lack of better things, lesion detection is critical, but everything can get us to lesion detection, including CTs. But what about lesion length and diameter? That's very important. It's very important because that can help us guide and plan how we're going to treat these subsequent lesions. Are we going to balloon them and stent them? And if so, what are the sizes we're going to utilize? Because we know we have a lot of choices, and we certainly don't want to under or over estimate the sizing of our equipment. Once we perform interventions on these patients, it's also very important to validate the results. Did the stent oppose nicely against the wall of the vein? Is there any residual narrowing? And most importantly, after placing a stent, is there any thrombotic processes that may have formed along the way? Because nothing beats real-time imaging with a three-dimensional view in our interventional space. But again, as we've all taken an oath in our respective practices and our studies, do no harm to our patients. And so IVUS limits contrast, and we know that it limits radiation exposure. So ladies and gentlemen, not only is this helpful, this is the right thing to do for our patients. But don't let me convince you, because there's plenty of studies out there that I'd love to share with you. The first one is by Dr. Raju and Dr. Neglin, and I must say that no deep venous talk should ever be given without giving due respect and credit to Dr. Raju and Dr. Neglin. And so their initial observations looked at patients that had diagnostic venography, and they found that the sensitivity for stenosis was quite low. In fact, approximately 34% of lesions could be missed. And what they also noted was that many patients that went on to get IVUS, those patients that had a greater than 50% stenosis by IVUS, many of them were read as normal by venogram. And so while higher percentages of stenosis with IVUS did correlate with abnormalities venographically, we could not just count on collaterals. Many times we would think to ourselves, well, if there's a collateral there, then it means that the stenosis is significant. And if the collateral was not there, maybe the stenosis is not. But they showed that you cannot rely on collaterals. That does not exclude hemodynamically significant stenosis. So venography is quite limiting. They went on to publish in 2002 in the Journal of Vascular Surgery a paper that compared IVUS directly to venography. And again, they concluded that IVUS yielded findings that were not obvious by venographic results. Well, how so? Well, injecting dye only would potentially hide details. And they further broke down what kind of details, such as webs. Intraluminal webs are basically scarring, synechiae, shelves that can form, finger-like projections that can form that you cannot just see on a two-dimensional venogram. Furthermore, extrinsic compression. If the vein is compressed from the outside and the dye is making its way up, you may miss the fact that there's a focal extrinsic compression because venographically you may not note that from a two-dimensional view. So they concluded that IVUS was superior, and they compared it to a single plane venogram to estimate morphologic degree of iliac vein stenosis. And they went on to say that it would underestimate a degree of about 30%. 30% of patients who have a symptomatic, significant lesion would be missed if you did not use IVUS. They then went on in 2006 to publish more about the characteristics of the lesions that IVUS helps us look at. And they very nicely broke down the different types. Well, we know that there's two main types of iliac vein lesions. There's NIVLs, which are non-thrombotic iliac vein lesions, and PTS lesions, lesions secondary to a history of a DVT. And so they nicely differentiated the two in that the lesions that were left behind after a DVT were more segmental, irregular, diffuse fibrosis that occurred over years. Trabeculae may be present. However, comparing to non-thrombotic iliac vein lesions, these are due to a focal extrinsic compression, and that could be very subsegmental, typically across arterial crossover points, which would make sense. And you can see here, there's multiple crossover points between the artery and the vein in the pelvic space. That intimate connection can lead to a significant area of narrowing both on the left and right side. But as you notice, if it's a non-thrombotic iliac vein lesion, it's very focal, which can lead to what we call pancaking. Pancaking is a compression of the vein, making it ellipse. However, us not being able to appreciate the elliptical nature based on just doing a venogram. So let's fast forward to 2016. And this was a very nice paper, a very nice trial that was put together that looked at venography versus intravascular ultrasound for diagnosis and treating iliofemoral vein obstruction. And how was this different than previous papers? This was different in that it compared multiplanar venography versus IVUS versus just single plane venography. So they looked at patients who had significant symptoms for diagnosing of lesions, and they underwent multiplane venography with an AP projection, LAO projection, and an RAO projection. Then they wrote their results down, and then these patients went on to get IVUS. And so the paper has been published in the Journal of Vascular Surgery, and this is for your reference. But the bottom line was that when we compared patients that had multiplanar venography to those that had IVUS, the paper found that 26.3% of patients that had a significant lesion were missed if you did not perform IVUS. So again, we owe it to our patients to use the best technology, to be as thorough as possible. We must utilize IVUS if we're going to treat people and treat patients in the deep venous space. So for the next couple of minutes, I just want to share some common pitfalls that I've learned along the way. And I've certainly made all these mistakes, so I'd like to share with everybody so that we all learn together. Some common pitfalls along the way as we're using IVUS and we're taking it up and down the iliac vein into the inferior vena cava. As we're looking at areas that are narrowed, we want to make sure that we compare like areas to like areas. In other words, if I'm comparing an area of narrowing in the common iliac vein, then I need to compare my standard to a common iliac vein area. So I don't want to compare a common iliac vein narrowing to a standard of an external iliac vein or a common femoral vein, because you're not comparing the same segments. So we must be very careful. And so if the area, the complete area on the common iliac vein is compressed, then it's not right to compare it to the adjacent segment. And in that scenario, we have to utilize the area method. And the area method has been published, again, has been brought forth by Dr. Raju, which basically is based on the pi r squared principle. And if you look at typical diameters of the common iliac vein, 16 millimeters, external iliac vein, 14 millimeters, and common femoral vein, 12 millimeters. And based on the pi r squared equation, the typical area method says that the common iliac vein typically should be around 200 millimeters squared. The external iliac vein should be 150 millimeters squared. And finally, the common femoral vein should be 125 millimeters squared. And so, not to make it common sense, what we want to make sure that if we have a common iliac vein where the area is significantly decreased, then we certainly can use that as a diagnostic tool. So I'd like to end with a case. And this is an actual case of mine. This is a 68-year-old female. She has a history of a recurrent left medial ankle ulcer. Ladies and gentlemen, for 6 years, she went from specialist to specialist, and she had this persistent ulceration that nobody could really figure out for her. She also had some foot and leg swelling along the way, but no trauma. She had multiple endovenous ablations performed at other practices because she had superficial venous insufficiency, which was rightfully so looked at. But the problem was that the vein kept opening back up, and the ulcer kept closing, or came close to closing, but then kept opening back. And so she was followed very closely with some good podiatry and wound care colleagues. Again, it's a team approach. This is her past medical history. She had a blood clot in her left leg about 15 years ago. She's had a history of arthritis, hypertension, and anxiety. Now, again, as we spoke of, we start with the least invasive diagnostic test, and that would be the pelvic venous duplex ultrasound. But oftentimes, again, in patients that have a lot of bowel gas overlying the common iliac veins, it can be very difficult to decipher the area and the diameter. And so that was inconclusive. So at this point, and this is what the ulcer looks like. So she's got left medial ankle ulceration, and then she's got a secondary one that's starting to erupt here. Very painful. She's starting to become depressed. She's a social woman. She doesn't want to go to church anymore. She feels that if she were to go to church, that people would look at her legs, look at her ankles, and would make her feel very, very conscientious of it. So we went ahead and did a diagnostic venogram on this patient based on her symptoms, based on the fact that her superficial venous system kept recanalizing, and based on the fact that this patient has an ulcer that is unrelenting. And as you look at the diagnostic venogram initially, you look at the left and right common iliac vein meeting in the center and going up into the inferior vena cava here. And if you look at it at first sight, we may think that, hey, there's dye making its way up, meeting in the center and going up rightfully. And so there doesn't look like to be much of an issue here. But I'd like to point out something a little closer. There's a little bit of there's a little network of collateralization that is occurring from the left external iliac vein across the midline here. And again, while collateralization is not always there, in this scenario there was. And so that certainly raises an index of suspicion. Why is there collateralization as dye is making its way up the left side rather than making its way straight through the left common iliac vein? And so had we stopped here, we may have not done anything other than keeping an eye on it. But we did go ahead and use IVUS. And so this is the pullback of the intravascular ultrasound catheter from the inferior vena cava, making its way down into the left common iliac vein. And what I'd like for you to see is I'd like for you to see how the lumen is irregular, how it's hugging the catheter, how there's little finger-like projections that are making their way into the lumen. These are all signs of chronic scarring that has occurred within the vein because of the fact that this woman had a blood clot 15 years ago. This woman has classic postthrombotic syndrome. She is walking around with an ulcer on her leg, on her ankle for more than 6 years without finding any answers for it. And so This was certainly looked at adequately with the IVUS. It showed us something that we did not see venographically. We went ahead, it helped us size our stent. We went ahead and placed a stent in her left common iliac vein. There you can see the final venogram. You can actually see there's no collateralization anymore. Well, how did this patient do? At 3-month follow-up, you see at the left of your screen, at 6-month follow-up, she had complete closure of her left medial ankle ulcer. This lady, this patient came back, a totally new woman in 6 months. She got her life back. She was able to socially go out and spend time with her friends. And it really is life-changing for these patients. Now, again, if we keep ablating the superficial vein, we're not doing these patients any good. We have to think outside the box. We have to think pelvic venous insufficiency, and we have to utilize the right tools. So in conclusion, percutaneous endovenous stenting has emerged in the last decade as a method of choice to treat venous outflow obstruction due to chronic venous disease. We have multiple papers that have proven this. There's a lot of publications out there. Stenting of the venous outflow obstruction in the lower extremities can be performed with in a low risk, long-term, high patency rate with low rate of in-stent restenosis. Dedicated iliac vein stents are here. If we're going to do it right, we have to make sure we're utilizing the best technology in our patients, become familiar with the dedicated iliac vein stents. And again, we thank them for their continued support for these meetings. We can't do it all ourselves. We need industry to get us the technology and advancements along the way. And as we're treating these patients, we must utilize IVUS. It is critical in determining lesion present, the presence of lesions, the severity, and sizing of our equipment. With that being said, I would thank you for your attention, and I look forward to hopefully seeing you in New Orleans in 2021. Thank you.